Yeah, so first one, so what is the definition? So a threatened miscarriage is a clinical condition where the process of miscarriage has started but not progressed to a stage where the pregnancy cannot be saved. This condition is characterized by vaginal bleeding in early pregnancy and closed cervical os and the presence of fetal cardiac activity. So what needs to be kept in mind? So closed cervical os and presence of fetal cardiac activity, which means the baby is still alive and cervical os is closed, which means it is not in the process of getting terminated. And but the thing is, the process of miscarriage has started but has not progressed to a stage where pregnancy cannot be saved. It can be saved. So this condition is characterized by, and what does it look like? Vaginal bleeding in early pregnancy. So which is what the heading of the unit is, hemorrhage in early pregnancy. So what are the clinical features? So bleeding with threatened miscarriage typically presents with following symptoms. So bleeding per vaginum and pain. So first one, usually slight and usually slight, which is the bleeding, may appear brownish or bright red. So brownish or bright red. Occasionally the bleeding may be brisk, especially in late second trimester, and bleeding often stops spontaneously. So that is about the bleeding. Next, coming to pain. So bleeding is painless, generally painless, but backache or dull lower abdominal pain may be present. Pain usually follows hemorrhage and may resemble menstrual cramps, which is very scary during pregnancy. Yeah, coming to pelvic examination. Pelvic examination should be performed with utmost care. So there is speculum examination and digital examination. So first one, speculum, reveals bleeding escaping from external os. So you look at external os and there you can see bleeding, and helps rule out other causes of bleeding, which is speculum examination, which includes cervical ectopy, polyps, carcinoma, ectopic pregnancy and molar pregnancy. Cervical ectopy, ectopic pregnancy in cervix, polyps, carcinoma, ectopic pregnancy in general, molar pregnancy. And digital examination, the cervical os remains closed in threatened miscarriage. Uterine size corresponds to the period of amenorrhea. Bimanual examination reveals soft cervix. So pelvic examination is avoided if ultrasonography is available to reduce the risk of disturbing the pregnancy. So we are done with history and examination. And now coming to investigations. So blood test, urine test, ultrasonography, and serum progesterone and beta HCG levels. The first one is blood test. So hemoglobin, hematocrit, that is for anemia and all that, and ABO and RH, specifically to look at RH negative side of things. So anti-D gamma globulin should be administered in RH negative women if bleeding occurs. So we are handling one aspect of miscarriage. Next, coming to urine test. Urine testing is an urine testing for immunological markers is not reliable, as they may be positive even after fetal death. So this is not reliable, urine testing. So but we still need to include it here, specifically for miscarriage, threatened miscarriage. Next, coming to ultrasonography. Well formed gestational sac and yolk sac with central echoes confirm a viable pregnancy. So there should be central echoes. Fetal cardiac motion on TVS, transvaginal, has 98% chance of pregnancy continuation. So we do TVS, we look at the fetal cardiac motion, and then we are sure 98% it is good, it will go forward, and the pregnancy is going to go forward. Yeah, anembryonic sac, which is empty gestational sac, is diagnosed if mean gestational sac diameter is greater than 25 mm without visible embryo, indicating early pregnancy failure. So anembryonic, the sac is empty with the sac size greater than 25 mm without visible embryo, that means early pregnancy failure. And finally, coming to serum progesterone and beta HCG. Serum progesterone greater than 95 nanograms per ml, 25 nanograms per ml indicates viable pregnancy in 95% of the cases. Serial beta HCG measurements help monitor fetal viability. Falling levels indicate poor prognosis. So one is progesterone levels greater than 25 nanograms per ml. Serial beta HCG measurements helps monitor fetal viability. Next, coming to treatment, rest and activity modification, medications, avoidance of coitus, follow-up and monitoring. So, first one, rest and activity modification. Patient should remain in bed rest for few days until bleeding subsides. That is one. Prolonged restriction of activity has no proven therapeutic value. So, you need to keep moving. That is what it says. So, it does not really matter if you take prolonged rest. Medications, pain relief, mild abdominal pain can be treated with diazepam 5 milligrams tablets taken twice daily. Diazepam 5 milligrams tablets taken twice daily. So, that is for pain. Progesterone therapy may improve outcomes by supporting endometrium and inducing immunomodulation. However, HCG therapy is not preferred. So, just progesterone therapy which supports the endometrium and induces immunomodulation. Sorry about that, the lights went off. Next, coming to avoidance of coitus. So, patients should avoid sexual intercourse for at least 2 weeks after bleeding stops to reduce the risk of recurrence. And then finally, we have follow up and monitoring. So, repeat ultrasound and beta HCG measurements. So, repeat ultrasound and beta HCG measurements are advised after 10 to 14 days to assess the pregnancy viability. So, ultrasound and beta HCG measurements after 10 to 14 days to assure viability. Next is serial sonography, monitors fetal growth and development. Next, coming to prognosis. So, overall the prognosis may be better to do this one. What is that? This one. What is it? Complications first, then we'll do, I'll just rearrange these topics. So, complications, miscarriage progression. So, threatened miscarriage can progress to inevitable and incomplete or missed miscarriage if untreated. So, threatened, so it is not bad yet extremely. So, but it can progress to inevitable, incomplete and missed miscarriage if untreated. Preterm labor, women with the history of threatened miscarriage have higher risk of preterm birth, and placental issues, increased risk of placenta previa, placental abruption, IUGR. Fetal anomalies, threatened miscarriage may be associated with fetal malformations. So, and also advice on discharge, we are not looking at conclusion, it is ChatGPT material, we are completely deleting it. Yeah. So, advice on discharge. So, the patient should limit activities and avoid heavy work until the condition stabilizes. So, avoid heavy work, limit activities, follow up with repeat ultrasound and clinical review after 1 to 2 weeks. Repeat ultrasound and clinical review after 1 to 2 weeks. Educate on signs of worsening such as heavy bleeding, severe abdominal pain or passage of clots, and advise immediate visit if these occur. Finally, coming to prognosis. So, I will just bring this down under this one, what is it, below the follow up thing. Yeah. So, prognosis of threatened miscarriage is unpredictable. In 2/3 of the cases, the pregnancy continues uneventfully even beyond 28 weeks. In the rest, the pregnancy may progress to inevitable, missed or incomplete miscarriage. This is very sad. Unfavorable prognostic indicators, falling beta HCG, decreasing fetal size on ultrasound, increasing irregular shape of gestational sac, presence of fetal bradycardia. So, with this we end the discussion on threatened miscarriage. So, in the next section we would be looking at missed miscarriage and also other things. So, I will terminate the video, not the pregnancy for now. Yeah, in case you like the particular video, you can like it and you can also share it.